So we're going to talk about contraception in the teenager. I already did my land acknowledgement, so I'm not going to do that, but I just want, this is the real rent, duwamish.org, if you want to learn more about the Duwamish people and their needs. Nothing to disclose, and I'm not going to discuss pharmaceuticals not approved by the FDA. So we're going to talk about trends in adolescent reproductive health. I know a lot of you know this, so that's why I always want to make sure that I have the availability for you guys to raise hands about this in the adolescent, because contraceptive options are something that is another topic near and dear to my heart. We'll talk about risks and benefits, strategies for counseling on the use of long-acting reversible contraception, or LARC, and talking about how to manage the common side effects. So we do know that pregnancy, birth, and abortion rates are declining in the US and have been for years. Teen birth rates vary, however, by age, race, ethnicity, and state. We still have the highest teen birth rate of any industrialized country. We also know that teens have less effective methods, and they use the methods that we do prescribe for them inconsistently. So what are reasons your patients might be seeking contraception? Well, they might be seeking it for heavy, prolonged periods, irregular periods, painful periods, to suppress menses, hyperandrogenism, or finally pregnancy prevention. So there's the last bullet you can see here is that way many might be considering a contraceptive method would be to prevent pregnancy. So this was an interesting study. I love talking about this because so many folks think that teens are just running amok. But actually, our studies continue to show that the numbers of high school students that have had sex is that 38% number, compared to a much higher number in the 70s and 80s. 27% had sex in the previous 3 months. But importantly, only 54% used a condom the last time they had sex. And 12% didn't use any method to prevent pregnancy during their last sexual intercourse. So again, you can see from the 90s here, it was about 54% of teenager high school seniors were sexually active. And now the number is down to 38.4%. So, which is a promising piece of information, yet why do we still have the highest rate of unplanned pregnancies in teenagers of any industrialized country? Our birth rate has gone down, though. So important to understand that the numbers in the 40s and 50s and 60s were at their highest, and the numbers have dropped to the lowest numbers that we've had. Still the highest in the world, but they are continuing to drop. So it's important to understand that. Also, that our birth and abortion rates have also been decreasing for those that talk about this in our country. And we definitely have had a decrease in pregnancy, birth rate, and abortion rates that has been going on since the 80s. However, when you look at it by state, you do see the states where the highest teen birth rates are right here in the dark red. And so this is where it's very important to be paying attention to the politics of our country and to look at the teen birth rates by state. Many of the teens who are pregnant in these states actually have planned pregnancies, and so that's important to be quite aware of this and not to be super criticizing and judgmental about this. However, many of these teen births could have been prevented because they didn't have proper access to appropriate means of reproductive care. And the ability to get reproductive care in many of these states continues to decline and will continue to decline over the next 5 years. So this is looking at the numbers compared to our country here and then other countries here. So you can see that this was a study from 2008. So while it might be a little bit lower now, it's still significantly higher than in other parts of the world. I think it's interesting that it's 3 times higher than in Canada, which is just 2.5 hours away. It's amazing how different it is in our country versus Vancouver, BC. So in 2017, there were about 194,000 babies born to teenage girls between 15 and 19. Again, this is a number that's decreasing, but it's still the highest. This just looks at teen birth rates across all ethnicities. You can see significant drop across all ethnicities from numbers that are higher in 2008 to numbers that are pretty close. We still have a bit of a higher bump in our Hispanic and Black teens, but again, I think it's because of access But we definitely are showing, if you look at the slope of the curve from 2008 to 2018, a significant drop than the teen birth rates from 14 years ago. And why did teen moms not use contraception? There's a thought that they couldn't get pregnant. The partner didn't want to use contraception. They didn't mind if they got pregnant. They had trouble with getting birth control. They were afraid of the side effects, or they thought they were sterile. Maybe they'd had something happen to them, a twisted ovary or an STI, and they thought that would cause infertility. So these are all myths that we can easily dispel in our clinics. The other piece that's really important is to talk about sex education in schools. I teach sex ed to 5th, 6th, 7th, and 8th graders and have been doing it for about 17 years, much to the chagrin of my children. I used to teach sex ed when they were in school. Yeah. I would think they would recuse themselves and not be in the class when mom was teaching this, or wear a paper bag over their head and just walk, or I don't want to. But they were in there. They wanted to hear exactly what I was saying to their friends because they wanted to be able to deal with it on the playground. Nope, that is not what mom said. I was literally in the room. And the irony is that since I've been teaching to these kids, now they're my kids' age, and I still see them sometimes when they come hang out, and they completely remember me talking about this, about abstinence and about condoms, about all of the different forms of birth control and sexuality and gender and just being able to say no, and how important it is that consent is bilateral. So I'm just, my kids are just we don't want you to talk about this, Mom, come on. We're watching the Sounders game, but I'm not even bringing it up, right? So their friends are talking to me about it. It's thanks so much, Cora, okay. So abstinence is something that is still frequently taught. I've written a policy statement on it for the Academy of Pediatrics, and it is something that is still taught in many, interestingly, of the schools in the states that you just saw were red. So in the states, in the areas where the abstinence is the best form of birth control is taught, that's where we see the highest teen birth rates. We know this. And yet, it still continues to happen and be funded in our schools. And the information that teens get about contraception or appropriate birth control is either from their parent or in the schools, but honestly, a lot of it's on the internet right now. So if they're not getting information from us as their health educators, they're just going straight to the internet or Dr. Google or some other platform to look up stuff. So if we don't answer these questions, they're very easily going to get these informations from other sources like YouTube. So when patients come to see me, do they come with a method in mind? Do they have any considerations that we need to talk about? We need to talk about efficacy, and we need to talk about short versus long-term use. We also need to talk about STI screens. Do they have any concerns regarding safety? And what's the issue around confidentiality? So the confidentiality pitch that I was talking to you about before is really important because, as you remember from the confidentiality piece that I said earlier, you don't have to tell the parent if the kid wants some form of contraception. Basically, the state of Washington is 13, but honestly, people go as young and not tell the parents about this if the kid doesn't want the parent to know. There's no reason you need to be telling the parent about this unless it's been as an abusive, non-consensual, then you would have to. So I think it's really important to lay the groundwork right away about confidentiality so that they know they can trust you with their contraceptive decision making. So basically it's different in other states. So we have literally crossing over into Idaho, Utah, Wyoming. It's important to be aware of the ages they can get contraception without parental consent. So sexually transmitted diseases, it's age 14, but again, reproductive health, there's no age limit. For an abortion under 18, you do not need parental permission in the Washington state. And just in general about mental health and alcohol and drug treatment, it's age 13. So in terms of medical considerations, which is really important, and we talk about this a lot in our clinic, is contraindications to hormonal methods that contain estrogen. Very careful about high risk of thromboembolism. It's extremely important to ask about migraine with aura, hypertension, complicated valvular ischemic disease, liver disease, or breast cancer in them. So it's something that we talk about estrogen quite often in our clinics when we have to talk about birth control, because there's so many other options available that we need to be very careful. We had a kid come in to the biofeedback clinic, my other clinic I run, and they had migraine headaches and wanted something for heavy periods, and they'd been put on an estrogen-containing birth control for menorrhagia. And they had migraines with aura, right? So they had definite like squirrely lines and visual cuts. And so a provider in the community, for their menstrual irregularities, had just put them on a estrogen-containing pill a few months before, and luckily, the neurologist who sent the kid to me for biofeedback had caught it. But if that hadn't, I knew they were going to catch it. But if that hadn't happened, we were going to stop that and try something else for menstrual control. But those are things that, again, I still see happening, and so it's. I know you know this, but just be very, very mindful of the concerns around estrogen. This is a super complicated slide, but this is the CDC medical eligibility criteria. I've been on this working group a couple times at the CDC in Atlanta, and this is really important in terms of medical eligibility, that you can look at the age of the patient. You can actually go into this chart and look at their medical disease and determine from the right-hand side of this eligibility criteria which is the most effective, safest form of birth control or hormonal regulation device they can use. And so obviously those that are in red, you would not use. And so it's important to be aware of the green versus the red. And I'll show you where you can actually put this here on an app. So this is a free app that you can have on your phone. I have it on my phone. It's updated frequently. And it has all the medical eligibility criteria on it. So if you download it onto your phone or device, you can see that there's a contraception, there's the eligibility condition methods, and other guidelines and provider tools. So if you are doing even more than once or twice a week prescribing, you should definitely have this one on your phone that you can easily access to help your patients figure out the safest form of contraception. So you can go through it by age, if they're on any other medications or retrovirals, what is the right form of contraception to use. So I love this site. Actually, I use it really frequently. And again, you can also get the tables and put them up, or get the MMWR report. There's multiple ways that you can have access to this information so that you don't cause harm by prescribing the wrong contraception. The most effective, this is something that we have in our clinics, laminated. It's in every single room, and it's from Bedsider. We downloaded it from them, and we use it frequently, and it's in Spanish as well so far. So I love it. It's got language that teenagers can use that works really, really well or not so well. So it's definitely, this Bedsider organization has used adolescents. They have their advisory group, contains quite a few adolescents, so they can make sure that the teens know what is the most effective form for them. And then they also did a pictographic too, which is what's your chance of getting pregnant? 1 in 100 up here versus 12 to 24 in 100. So this one, actually, I say when a kid is using condoms for birth control, I say, well, what percent chance you could get pregnant if you were on the condoms? And they're like, I don't know, 95, 100% effective. I'm like, no, it's about 82% effective, using condoms only as a form of birth control. And then they say, well, that's okay, isn't it? And I'm like, well, that's a B-. So if you want a B- in preventing an unplanned pregnancy, or would you like to get an A+ in that one? And they're like, well, I want to get an A+. Like, well, then you need something else besides the condom. So I always use that 82% a lot when I have kids wondering whether they should use something else in addition to condoms. I talk about that more. So go ahead and take that one and use it, because it works really well to get someone to use something else in addition to condoms. So we definitely talk very much about using the IUDs, either the Mirena, the Liletta, the Kyleena, or the Skyla. There's 4 options available. And it's the LARC that is the most effective form of preventing unplanned pregnancy. We don't say best, we say most effective, because it's not okay to say it like that, so you have to just say most effective. It's much more real in terms of what it is. And we use the Mirena pretty much always. The reason people use the Skyla or the Kylena is a little bit smaller. So for the nulliparous, there's some thought that it might not fit or be harder to put in. We have not found that at all. And we have 4 gynecologists that work in our group, and 5 of our adolescent providers put in IUDs. So we've got 10 folks that are putting IUDs, probably 5 or 6 a week in our clinic, and we only use Mirena. And it's got 52 milligrams of levonorgestrel in it, and it works locally. So it works by thickening cervical mucus and atrophies the endometrial lining and inhibits the sperm. And it's a progestin-only method. So for those that have any issues around estrogen, this is one of the very important things to talk about. It partially inhibits ovulation. So it really just works locally. It's not a systemic method of birth control. And this one is really important to talk about. It isn't, I don't want to be on this because it's going to inhibit all of my, inside hormone systems. Like, well, actually, that is not how this works. It works locally, pretty much only in your uterus where it is. And it only partially inhibits ovulation. So that's one of the things so occasionally you hear about someone that might get pregnant or might still have periods, and the pregnancy could be the 1 in 100 is because of the ovulation continues and maybe the mucus was thinner that time. But it is important in terms of if you have someone with cysts or endometriosis, that's why it might not be the proper thing to use for someone like that. They just approved it for 7 years, the Mirena. So that's the other reason we use Mirenas, because the Skyla is really only approved for 3 years of age, 3 years of duration, and the Kylena for 5. Use failure rate is about 0.2% after a year. There's some discomfort with insertion, so we absolutely talk about that. We don't sugarcoat this, and we do talk about the fact that it's gonna hurt when you get it. We do have benzodiazepine in our clinic, so we have Ativan in the clinic, and we do have topical lidocaine, which we use the lidocaine some, but we very rarely need to use a benzo because they have to have someone drive them home when we give them that. So that sometimes puts the kibosh on use of something like that. So they can have cramps or irregular bleeding the first 6 months to or so after they have the IUD placed. But ultimately, they'll have lighter periods or even have no periods at all, which is a big positive selling point for this particular form of contraception. The Paragard is a copper container. It's still available. It can last up to 12 years, but it's approved for 10. It creates a foreign body reaction within the lining of the uterus. It also impairs sperm function. Failure rate's about 0.8% after a year. It can be used and placed for emergency contraception. So if you have someone that's had unprotected sex, they can have the copper IUD placed. They still haven't approved the Mirena or the Skyla for emergency contraception. They're trying to get that pushed through, but that has not been pushed through yet. People that have the Paragard, the copper implant, will still probably have periods. They might even have heavier periods with significant cramping around the time of their period. So yes, it's the kind that doesn't contain any kind of hormone, but yes, it also has some issues around cramping and heavier periods. But some of our patients really don't want the levonorgestrel, they want copper. So we can put those in too. So the next one on is another LARC, long-acting reversible contraceptive. It contains 68 milligrams of etonorgestrel. It does work systemically, so it inhibits the LH surge and can prevent ovulation. The FDA has approved it for 3 years, but it could possibly be approved for 5 years in the next year or so. There is evidence for efficacy for that long. There can be some issues around larger-bodied women, assigned women that have BMIs greater than 28, so there's a little bit of concern about how long the Nexplanon can stay in our larger-body patients. They can have irregular bleeding. Up to 30 to 40% of women will have amenorrhea, and the rest can have regular periods or continue to have continuous periods, which is another reason for failure rate of use. We talk a lot about this because they can have irregular bleeding for about 3 months, but they need to kind of hang in there with it because 30% of all users will have amenorrhea at 1 year. And we talk a lot about how long they're bleeding and really do a little bit of counseling on it, because a lot of people stop taking it because they just really don't like the bleeding. Sometimes they have bleeding after sex, but sometimes they can have issues around pretty significant bleeding that cause them to have it removed. But if it is something that, if they have contraindication to using estrogen, it is something that we talk about. If we can hang in there with it for the first 3 to 6 months, it's a good long-acting reversible contraception. So for those that have bleeding on Nexplanon, we recommend non-steroidals, which can inhibit cyclooxygenase and prostaglandin, which would be 800 every 8 hours for 5 days while they're bleeding, or mefenamic acid. We don't use that very much, but some people do. Sometimes people who have bleeding on the Nexplanon, we are using estrogen-containing OCPs for about 3 months to see if we can stop the bleeding, which I know feels kind of counterintuitive. You've got an Nexplanon in someone and you're going to be using the pill too. Wow, really? But we do sometimes need to do that to stabilize the lining, and then we stop the pill and see if we can get the Nexplanon, just using the etonogestrel to work on its own. But it is an issue with Nexplanon, with the bleeding, but we are able to keep a lot of Nexplanon in by using nonsteroidals and a short trial of an estrogen-containing OCP. So we encourage them to try to leave the device in. If their quality of life is not impacted, if they're just wearing a panty liner once and then changing it and using it daily, we really do a lot of convincing women to keep the Nexplanon in if we can, versus having to take it out, because it's better than going through all of the issues around which pill to use and what other options, which we'll talk about in a minute. So if we are going to pull out the Nexplanon, we talk to them about maybe switching to an IUD before it is being removed, just so that we have something else to work for contraception. In the, about 17 years ago, LARC use was really low. So you could see that long-acting reversible contraception in 2005 was 0.05%, and in 2013 was 1.6%. So the red's the IUD, and the blue is the Nexplanon. And then we use Nexplanon, not Implanon, because Nexplanon is radio opaque. So if you hear Implanon, no one's really putting that in because it's not radio opaque. You can't see it when you do an X-ray. But Nexplanon is what we're using, and that's the blue. As you can see, significant increases just in the last few years. So I think we're on the right track. It's still low. We would kind of like it higher, to be honest with you, because of the duration of contraception in these kids. But we're getting there. There's doing just a lot more push to put LARCs in kids in high school versus the pill. And this was recommended by the AAP position statement that I helped write, which was talking about LARC methods. It should be considered first-line contraceptive choices for adolescents. Any questions about this? Because I know I get some pushback from the kids about not wanting something in their bodies. Or does anyone have any questions about sort of scripts on how to talk about this with their kids, or you feel it's not that hard? Okay. Depo is our next line. So it's an IM injection that's given every 3 months. So for those kids that are really, again, you can't use estrogen, they don't want to have an IUD or Nexplanon, but they can't remember to take something every day. We talk about Depo. We actually give quite a bit of Depo in our clinic. Higher doses can suppress LH surge, which causes endometrial atrophy. It lasts for 11 to 13 weeks. So it's a good form of birth control. And so, like all progesterones, it increases the viscosity of the cervical mucus. So we do use a lot of this for not only for contraception, but also for menstrual suppression and our gender-affirming care clinic. So it's something that is very important. But the thing about Depo is that we do have irregular bleeding that we can temporize with nonsteroidals. There can be increased appetite, so that there could be an 8 to 16 pound weight gain in the first 5 to 6 years. And we do know that those that have a higher BMI can have more weight gain in the first 1 to 5 years after depot than those who don't. The bone density issues are concerning, so we always check vitamin D levels and make sure that they're taking in enough calcium when we do our follow-up visits. And we reevaluate at 2 years. Consider doing a DEXA scan in someone that's on depot for over 2 years, just to make sure they haven't lost bone density. They get the bone density back if you stop the depot, but it is something that to be aware of. It isn't a reason not to use it, but it is important to sort of stay on top of it. If kids really just want to be on depot, okay, but we need to do a DEXA every 2 years while you're on it. The next are the combined hormonal methods, which are pills, patch, or rings, which is the form of pills, patch, ring containing both estrogen and progesterone. So the estrogen suppresses FSH with no follicle development, and the progestins suppress the mid-cycle LH surge. So both of them, the progestin stops the ovulation, and the estrogen stops the follicular development. So it's just important to kind of recognize how each one works. The risk of venous thromboembolism, 3 to 5% increase in people taking combined oral contraceptives compared to those who don't. And it's 10 to 35% times higher for those with factor V Leiden heterozygotes plus combined oral contraceptives. So the absolute risk of non-fatal VTE remains low, about 4 per 100,000. But it's important to recognize that in the first 12 months of initiating the pill that you're more likely to have a thromboembolism. So that's why it's important to take a really good history of migraines with aura, a past family medical history of venous thromboembolism, factor V Leiden, heterozygoticity. It's just important to do that before you are prescribing. The side effects of the combined oral contraceptives are nausea, breast tenderness, and they can have breakthrough bleeding. The failure rate with perfect use is about 0.3%, but we do have a failure rate of 7% with typical use, which means that, and this is the problem with this form of contraception, is if kids have serial monogamy, so they have somebody they have a partner with, they have sex with that person, and then they break up, and then they have a few weeks off, and then they go out with do some other relationship and then have sex, they start and they stop and they start and they stop taking the pills, which leads to a whole lot of confusion around this. So that's where you see the failure rate really high. So you have to be very on top of this in terms of if you've noticed that today's Wednesday and Monday and Tuesday are still in the pill pack, that means you missed 2. You really can't take 3 today because you're going to feel terrible. So let's like rethink what's going on right now, and maybe we need to start talking about a LARC method. So I do it that way, which is when you take your pills, is there ever like a couple of days that are still in the week that you haven't taken? Yes, well, nobody's mad at you, but let's sort of think another more effective way of keeping yourself from being pregnant now. There's also the monophasic pills and difference between biphasic and triphasic pills. I remember when the triphasic pills came out because it was a gradual increase dose of estrogen during the cycle. We really don't recommend triphasic pills at all right now. It's super confusing for kids and families or whoever to remember which ones to take, especially if they miss one. Should they take 2 of the other one? So we don't, in our group, ever prescribe biphasic or triphasic pills at all. And so we usually use orthocycline Sprintec or Avian Lutera. So the higher dose of, the middle dose of ethinyl estradiol, which is orthocycline or Sprintec, is usually our go-to starting pill. We very rarely start with a low dose estrogen, and I'll talk about that in a sec, because it's just definitely has a significant number of side effects with the lower dose than with the 35 or 30 mics. This is an app that you can put on your phone about contraceptives, especially if you're using a lot of this in your practice, because kids or families will come in saying, well, we're on Lutera, or we're on LS, or we're on blah, 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 another name of something that you haven't even heard of, another generic or trade name that the insurance does cover. This does cost $4.99 to have, but that's not very expensive if the kid's coming in and you don't know what it is that they're taking, but they do know the name of it and you've never heard of it before. And it'll talk to you with pills list by name, estrogen dose, progestin, FDA approval, efficacy. It's a really, really cool app. So I know it's like, I don't want to pay for an app, but this one actually I have paid for. It's a really good one to have on your device just to get at quickly in terms of staying current with what actually someone's taking. So like this, it'll break it down by, especially if you're trying to talk about androgenic versus non-androgenic activity, for those of you that have patients that have acne or other things, and it'll talk to you a little bit more about how to prescribe. Talk about dose and monophasic and approval. Oh, this is what's interesting. All of the equivalent pills, it'll give you all the names that people have in their group. There is a patch called Xulane, which delivers 20 millimics of ethinyl estradiol and 150 micrograms of norelgestroman daily. The issues around the patch, as you probably know, is a higher VTE risk. So it's not a reason you shouldn't use it, but it is one of the reasons why we don't use continuous patches, is because of the VTE risk. So you can do continuous cycling with birth control pills, which I'll talk about in a second, but we don't recommend that. Some do, but it is not recommended, and it's not supported through FDA prescribing. So it would be changing the patch once a week for 3 weeks, and then the 4th week is completely patch-free, and they have a withdrawal bleed. It's, again, one of the issues that has not been studied effectively is in our patients with larger bodies. It may not be as effective, although we don't know that definitively. So it might not be something that you would think about in someone with a larger body assigned female, but people do, they just need to be very careful. There's the NuvaRing vaginal ring, which is ethinyl estradiol and etonorgestrel. You can leave it in for 3 weeks. Many people leave it in, take it out if they're having an intimate relationship, or just leave it in the whole time. Remove it to allow for 1 week of withdrawal bleed. So there's lower serum estrogen systemically in the ring. So many prefer this as opposed to the birth control pill because there's lower serum contraceptions of estrogen. It's a good medicine, a good form of birth control for people on other medications because the first pass method is not how it works. It can cause increased vaginal discharge, however. So again, you have to be comfortable putting a NuvaRing in your vagina, but if you are, it's a pretty effective way to contracept that has a lower systemic dose of estrogen. The progestin-only mini pill, a lot of our folks want to do if they don't want to use the LARC methods, but they can't be on an estrogen-containing form of contraception and they don't want to be on Depo. So norethindrone is called the mini pill. It's 0.35 milligrams daily of norethindrone. The thing about it is it needs to be taken at around the same times every day. I mean, not the same minute, but it really should be taken within an hour or so at the same time, which is sometimes really hard for our teenagers to do. It works like we were talking about all the other forms of contraception that are progestin only. It thickens the mucus and makes the endometrium less amenable. It diminishes after about 22 hours, hence it wears off. So it's really important that because it doesn't consistently suppress ovulation. Unscheduled bleeding is very common in this. So we have a lot of families that want to use this in their kids, and that's okay, but they have to be very careful about taking it at the same time. There's also a new progestin-only pill called drospirenone, which is SLIND, 4 milligrams daily. It's a 3rd-generation progestin, and it can work as a mineral corticoid, which is kind of similar to 25 milligrams of spironolactone. So it's something that some people use as a progestin-only form of contraception for those of our patients that have acne. Longer half-life, so you don't have to take it exactly at the same time every day, and there's also less risk of unscheduled bleeding. So keep SLIND in your mind in terms of those that want progestin-only form of pill contraception. So what are added benefits of using hormonal contraception? Well, it also can work with those who have super heavy periods and can help treat and prevent anemia. And it can also work against developing endometrial cancer. The estrogen-only containing methods can have an anti-androgenergic effect, so it can improve acne and hirsutism. So there are some benefits if there's no contraindications to using an estrogen combined birth control pill in terms of helping those patients that have hirsutism and acne. So that's a reason to use a combined birth control pill in someone that has PCOS, for example, with acne, hirsutism, and irregular periods. Barrier methods are still the best method for preventing STIs. They published a study about 2 years ago, maybe 3, that unfortunately the benefits of using LARC is that it's longer and something you don't have to remember to take every day, but our kids were not using condoms because they were using LARC. So they were less likely to use condoms, so they were getting more STIs. Whoops. So that was a bit of a problem. And I do mention this study to my kids. It's like, and the theory was that the people that were intermittently taking the birth control pill, that's why they were using condoms and the birth control pill. So they were having less STIs because they were not using the pill effectively. Now that they are on an effective, good form of birth control, but they weren't using STI protection. So we have to continue to talk about condoms and dental dams. Dual protection guideline is again, something the CDC has recommended for years. So we do need to continue to talk about STI, HIV prevention. So that's why we continue to push condoms in all sexually active teens. Have to talk about emergency contraception. This is something that has been available without prescription. I'm very proud of the work that I did on this, which was just huge about 10 years ago now, where it became available without prescription and with no age limit. So it's expensive though. So it's 1.5 milligrams of leave-in norgestrel, so it's progestin only. Prevents follicular eruption, and it is not an abortifacient. So it's very important to be aware of this. FDA has approved it for emergency contraception between 72 hours of unprotected sex. Off-label, many people recommend that it can go up to 120 hours after unprotected sex, but the FDA has approved it for 72. It's just less likely to be effective after 3 days versus up to 5. It is not necessarily, there's no negative outcomes of repeated use. Some people have said, well, if you use it over and over again, then it affects you forever. I'm not sure where that data came from because that's not true. If somebody is already pregnant, it's not going to cause, like I said, it's not an abortifacient, so it's not going to prevent a pregnancy if pregnancy's already occurred. Ella is another form of emergency contraception. So for Plan B, you don't need a prescription. The problem with Plan B is it's about $50. So, and again, what they don't have it just out next to the condom section. They usually have it behind the areas where the super expensive creams are. So you have to go, not to the pharmacist, but you have to go to the person at the cash register and ask them to unlock the thing that has the L'Oreal creams and all those things in it to get it. So it's super embarrassing for kids, but I just say, you really need to make sure that, if you're going to go in there and do it, you have to have enough money to pay for it. But you shouldn't be turned away from getting this from anywhere that stocks this. It's absolutely should be available. And you can write a prescription for it, and so I do write prescriptions, and insurance does cover it, but if you are writing a prescription for it, then it goes into the explanation of benefits, and the family does find out about it, that went onto their pharmacy package, so therefore, it's okay to write a prescription, and you should, but unfortunately, sometimes the families might find out about it versus the kids just buying it themselves. Ella is only available by prescription, so it isn't, you cannot buy this without one, but, and most insurance companies will cover this easily, so, and it prevents, and it does have FDA approval for up to 120 hours. So it does have approval for the extra FDA approval for the extra couple of days after unprotected sex. It's sometimes costly and sometimes it's hard to find it. So it's not every pharmacy stocks this. We have it on our formulary at our hospital and we use it frequently. But it's just important to be aware that if you are writing a prescription for this, you have to tell the patient they may not be able to find it. So get them another prescription for something, for Plan B as well. So I just want to end, I think I did it on time, you guys, with to make sure that, that just a plug to we continue to fund confidential family planning and preventive services. Huge plug to continue to fund this. That you know that there's pros and cons of different contraceptive methods. Choose wisely, have the teens choose wisely as to which method they're going to use. Because honestly, there's nothing more frustrating than having them decide something and then come back in a week later and say, I don't want to do that, so can you just stop? So really important to make sure that teens are part of the decision as opposed to what you think they should be on, is that they decide what they want to be on and that they need to stick with it. LARC is the most effective and safest first-line choice of birth controls according to guidelines from ACOG and the Academy of Pediatrics. But it is sometimes hard to convince someone to do this, and so there's ways to bridge that until they make a decision. And we never want to force anybody to do things. There's been too much forcing of kids to be on things over the years, and that is not our goal at all. This is the choice that they need to make. It's their bodies. They have autonomy. They get to decide, not us. So make sure that it's, again, a joint decision as opposed to a top-down decision, because that never goes well. This is just some resources for you to look at through the CDC, National Campaign to Prevent Teen Pregnancy, Planned Parenthood, and Guttmacher. Guttmacher is the organization that has all the consent rules and all of the evidence and scripts in terms of what's happening in the states. So if you want to kind of stay current on laws that are going on in the country right now regarding reproductive rights, go and get Guttmacher kind of as one of your like go-to places, because they do really good work and just really keep the public informed on what's going on in terms of reproductive rights and abortion, et cetera, access to reproductive health all over our country. The Young Women's Health site out of Harvard is also really, really good. So if you want a site where you can download really good handouts in multiple languages for your teens and families, this Center for Women's Health has been around for about 30 years. It's updated. It's got a whole lot of teens that are helping write this information. I love this site. So this is on one of my favorites for my clinic. I print these handouts at least once or twice a day. As I said before, Bedsider is a really good site that is about and for not just teen women, but all women or assigned women or gender-affirmed women in terms of talking about birth control and methods and reminders. And it's got all sorts of links on it about how to remember to take your pills or how to do menstruation apps to figure out when you're going to have your period. All sorts of blogs and questions. And I love this site. It's really fun to kind of play around with it. Okay, so wow, I was with you guys for a long time. I really appreciate your time. That's my email again, and my Gmail, and my cell phone. Thank you so much for your time. Do you have any questions for me? Thank you, yes.
We're going to talk about low-dose birth control pills.
Right, thank you. So the 20 microgram estrogen pills, honestly, a lot of people want to be on those because it's lower estrogen, but there's a lot more breakthrough bleeding. They can still intermittent, they might ovulate. It sounds better, but if you look at it in terms of effective contraception, it isn't. And they just have a lot more spotting and just stuff they didn't realize was going to happen. We kind of really, if we're going to use the method that's the most effective and simulates more what's going on, we should use 30 to 35, because that's what our bodies do. And we're actually shutting down our whole hypothalamic axis when we take the pill. So if we're using 20 of, that's not effectively shutting it down, so that our body's really confused. And so the downstream effects are maybe that you would even have more estrogen in your system, if you think about it, right? So, I mean, I have to have this conversation because the family's like, I really want to be the lowest dose possible, to have the least, I'm like, I get it, but they're still going to spot, and we're putting them on it to control their bleeding. And so we have to do a lot of convincing. And there are some cultures that really, really don't want their kids on the pills at all, which is fair. I understand all of that, and we just have these conversations about it, and they want to do it. And I say, yeah, but the downstream effects are going to not be even what they want, so they're going to stop it. So I don't ever really, I mean, we can't, sometimes we do because we're kind of forced, but we end up going up to 30 to 35 within a month or two. Yes, ma'am. So the question was, will ELA or Plan B work in larger-bodied women? They have not had any data to show that yet. So it is on, that's why I'm pausing, because it is on Google. Just take 2 of them, is what somebody wrote somewhere. Like, that, what? There's no research at all that says that works. I mean, to be honest, it's a whole other talk I can give. There's a whole lot of research bias on a specific size person, and not enough research dollars are being spent looking at our larger bodied folks, and there's just, no, you have to fit into this paradigm, which is why. So we don't know yet. But it is worthy of further discussion, because I think we need to do that. Correct. So we don't have evidence on larger people with higher BMIs, but so we don't know is the answer. Yeah.
I thought there was a study several years ago.
Right. Yes, so to your first question, that study did come out a few years ago, but it hasn't been confirmed really, so that was that one. It's like a hypothetical. Maybe it won't work as well. But what I want to know, and I don't know that, I'm going to have to find out and get back to you, is are there women that have taken Plan B, larger body, that have within whatever, 72 hours, that have gotten pregnant? I don't know that in the last few years. Because that would be like grounds for, we need more studies. This is not okay. There's a huge swath of people that aren't getting information that they need. And so the second question is, can you use the ring continuously? Yes. You can leave it in for 3 weeks, take it out and put a new one in right away. Yeah. Right, no, that's really, and same with the patch. It's also hard to remember it. And the patch it's frustrating because there's only one color, right? It's like, it's not clear. So it's, I mean, I have a lot of issues around why did you pick that color for the patch, but, and you shouldn't put the patch on the breast. You should only put it on the arms or legs, abdomen. But not on the breast, and it stays on in the shower. The adhesive for the patch is pretty phenomenal, how long it stays on. Any other questions?
There's like, I don't have knowledge. And the last sex that I had was fourth grade, like quick, like basic diagnosis. And I think there's also lack of knowledge. Because I don't think it's shared enough with us as kids. And a lot of the girls I talk to are just like finding having their parents. And I don't think knowledge that the staff have about. I just think that's a big issue.
Wow, what's your name? Olivia. Wow, what a cool person you are. That's exactly, you're right. All I'm going to say is you're right about all of it's correct. Yes, the summary was what Olivia said. The reason I'm an adolescent medicine doctor is this person right here. There's not enough information that's taught in high schools, none. She's got a lot of friends who are sexually active that are in morbid fear that their parents are going to find out. They're only getting knowledge on, you didn't say this, but I know that they're getting their information somewhere, and it's probably from the internet, which may or may not be true. I mean, if you go into Bedsider, you're going to get accurate information, right? But wouldn't it be cooler if you went to your healthcare provider for the information? So you're right about all of it.
Yeah, and I also think, like, I didn't even know about, like, about stuff under, like, those ages that we stated before. I didn't even know that, because I tried to, like, talk to my friends, because I do have an IUD, and I tried to talk to my friends and be like, oh, no, it's totally fine, so into it. But, like, there's no, like, definite answer, like, I think that says that, our parents
That's true. The question was, how do we get kids to realize that they have some autonomy around reproductive health at a specific age? It's so important to do that. And you point out something that's a glaring error in our system, because we do need to talk about that at our kids, which your parents don't need to know about this. You have the right to your body's autonomy in this state at 13. So thank you for that. And thank you guys, I appreciate it so much. And now it's time for the raffle, right? Wow, missing that. But
I was going to say, I used the 11, 12-year-old well child check to let them know that if they want to come back and talk to me about anything sexual or anything mental health, that the Washington State is 13 and up. So I just kind of leave that door open. And that's after I've already asked the mom and dad to leave, and we just say, this is your private time now, and you can talk to me about anything. And so I get that plug in there during that time.
Good point, yeah.